Welcome to It's Your Case, presented by VetCT.com. I'm Amy Zalcman, your radiologist on demand for this week. We continue with this month's theme of the gastrointestinal tract. Today's case is a 6.5-year-old female spayed Doberman pinscher with a history of elevated liver enzymes, polyuria, and polydipsia, as well as a 25-pound weight loss in the last 3 to 4 months. In the past 2 weeks, she has been vomiting and is now completely anorexic. She's quite ill on presentation and borderline hypotensive. During initial ultrasound, there is reverberation artifact, which is gas shadowing, near her liver, which obscures a complete evaluation of her cranial abdomen. Radiographs are pursued to assess for a pneumoperitoneum. There is generalized loss of serosal contrast in the cranial abdominal cavity, with a mild, non-homogeneous increased opacity throughout the region of the mesentery. The visible portions of the gastrointestinal tract, including the stomach and small intestine, contain a small amount of gas. There is not really strong evidence to suggest that there is gas within the peritoneal space. There is mild corrugation of the descending colon, which can indicate either mild irritation or colitis, as well as increased motility or peristalsis. The kidneys have a normal size and shape, and there is no mass effect that's observed. Incidentally, we do note that she has thin or thready pulmonary vasculature, and on both lateral views, her caudal vena cava is quite narrow. This is consistent with hypovolemia. So our loss of serosal contrast in this patient would indicate that she has a small volume of peritoneal effusion or steatitis, which is also akin to inflamed fat. This doesn't answer the clinician's question of whether or not the patient has a small volume of peritoneal gas. And so a technique that we can sometimes use is called a horizontal beam, in which the patient lays on their side or on their back for a period of time, and we allow gas to accumulate in the non-dependent portion of the abdomen, and we orient the X-ray beam across the table to the plate lying behind the patient, so in this case along the dorsum, but we allow that gas to potentially accumulate in the non-dependent region. But we're not allowing the patient, we're not shooting the X-ray beam from a top position towards the table. So basically a cross air or a horizontal beam. In this view, what we see is that there are a couple gas bubbles that accumulate just below the margin of the abdominal wall. We do see several gas-filled small intestinal segments in this area, which then call into question, are these truly outside of small intestine, or are they within intestinal segments? And so we do have to consider the potential that these might actually represent extraluminal gas foci. If we give this patient a little bit more time to lay on their back and allow the gas to aggregate a little bit more, we start to see that there is more accumulation of gas as a gas cap in a non-dependent region. We also see that there are smaller gas bubbles that accumulate that haven't joined this larger gas cap that don't appear within gastrointestinal segments. And so we now have confirmed that this patient does in fact have a pneumoperitoneum. And this indicates a ruptured viscus, likely of gastrointestinal origin. Taking the entire clinical picture together, between the loss of serosal detail indicating effusion and steatitis, as well as the presence of peritoneal gas, we have indications that the patient likely has a perforated gastrointestinal tract, and this represents a surgical emergency. We can confirm that the patient likely has a septic abdomen with evaluation of abdominal fluid, assessing for intracellular bacteria. However, we do need to complete this expediently since this patient is a surgical emergency. If this patient has not had prior surgical intervention or a centesis performed. If we review our initial images again with this now knowledge that the patient has peritoneal gas, we can start to see the hint that there might actually be some gas nestled amongst the region of the liver where there is no, or there shouldn't be, segments of small intestine. However, that volume in that region is difficult to assert confidently that that would be a pneumoperitoneum alone. The outcome for this patient was that they were stabilized, went to surgery, and a duodenal perforation was identified with septic abdomen. Be sure to view the full report associated with this case, and thanks for listening. Remember, it's your case, so please post your questions on social media.